this mix partly between the vascular workforce, training and certifying millennials, and I would be interested to hear how we manage expectations for our future workforce, particularly relative to what kind of schedule they want. There's some suggestion in literature that shows millennials prefer to work less than what boomers did, and so when you go to the C-suite and say we need another FTE, I don't know why, but those abbreviations still bother me some. We need another vascular surgeon, and they expect the same productivity, the same clinical output. How are we going to manage that both from the C-suite, the hiring side, and then also the expectations of our new surgeons who come into the workforce? So Fred, Gib, Mal, anybody who wants to hop on that. You too, Chandler. I'm not going to leave you out.
That's a fairly open-ended question.
Right.
Well, well, first, two things, some observations. I know, and maybe this in generalities is true about work, the millennials and work, but, I have in my group at least 5 millennials. These guys work their tails off, and I don't get a lot of, I'm working too hard, I need this and that. And so that may be out there, but I have to say that I'm pretty impressed with the millennial workforce and actually their work ethic. It's at least my experience is that they will respond when challenged. I do think, and I kind of alluded to this, that we that are in positions of leadership need to be promoting, number one, their well-being, but also we need to inform the C-suite of a lot of things they don't know about us when it comes down to hiring. There needs to be some clutch in the system. For instance, if you look at a very busy hospital, our hospital is relatively small compared to some of the hospitals that you all work in. And if you look at the activity, the amount of unexpected consults and requests for vascular surgery services, I think you can make a very good argument that there needs to be an additional FTE just to allow for that. I think that's part of the problem. I mean, you get called, you got to cancel your clinic, you got to cancel your operating room, you got to, then things start to back up. And when you talk about burnout, that's burnout. So I think we need to be aggressive about that. And again, I go back to this vascular certification thing. This thing could be, if you will, a great weapon to make that happen. When the review comes in and they review and they see what's going on and they say, another thing you need to do to be certified is you need to provide an FTE or additional people to help kind of put some clutch in the system and not make it so stressful for the individual surgeons that are in the center, because that compromises care.
Mal, you want to add?
Yeah, so we're, and you've seen this, Will, it's like time is a flat circle, right? So we need more vascular surgeons. So let's recruit. And we're going out, we're recruiting all these good young people. Then all of a sudden, like now there's too many of them and now they're not, the programs are overset. So now we need more programs. So we go out, all right, we're going to get more programs. We did 20 programs in 3 years, so we get more programs. Now we need more recruit. But it's a good problem, right? We are increasing the workforce probably for the first time in history in a real way over the last 5 years. So there has been a big change. But then now all of a sudden everybody's burned out. So Dawn and I are trying to work on the wellness project. So we're going to make sure we got more vascular surgeons, more programs. Don't burn them out. And I think where we're headed is probably away from fee-for-service, right? Because there's no way that this can continue like this. And so eventually, I think that we're going to be in a capitated healthcare system where you get 100,000 people, keep them well. And at that point, all this stuff about fighting who's going to do the SFAs, who's going to ablate their veins, that all goes away, right? Now we're just trying to keep people healthy and happy. And that's why I think that's when we will really flourish, because we're trained to do that. We're trained to comprehensively care for people for the rest of their lives. And that's why I think we're in a great position going forward to do this. I still encourage young people to pursue vascular surgery, because where healthcare is headed is where we're already at.
Sounds like you want to work for Kaiser. Dawn, you look interested in participating.
Well, I do want to say that it's a really good time to think about this because if nothing, COVID has shown us that we can work differently and we should work differently. And so we're busy and people might be burnt out. Not everybody's burnt out, but I do think people are frustrated. And when you're busy and you think about being busy, do you have to be the person doing all of the things that you do? I think about the types of patients that come to my clinic and how I spend my time after hours, and I'm positive that I don't have to be the person doing those things. And so in addition to expanding our workforce, I think it's really important that we focus on executing our specialty, meaning vascular surgeons should be providing vascular surgical care to the appropriate patients and being valued for that time. But our millennials and all of our older established surgeons should be empowered to at least have some control over their schedule and their practice, and we have to be extremely intentional with how we're recruiting and expanding our workforce.
Thank you, Dawn. Dr. Mulner.
As a surgeon who works in a smaller city, I don't really get to interact with people who are doing our education as much. Chandler's message about having a child that changes your perspective on things. I have a son who's a dyslexic learner, and learning about how he's going through this system. We have 20% of people who are dyslexic, are the estimates now, 1 in 5. Is our educational system able to adjust and bring these in? The millennials who are dyslexic, they learn alternate ways. As educators, I can't get through to this kid. He just won't listen. Well, maybe it's not the listening, maybe it's the message. Maybe we need to change the way we're doing things. Is our answer with getting more millennials involved, changing the way our educational system works, our process? Do we have a system that's flexible? Can we adjust?
So great question, Jonathan. We have a lot of educators here. How would you respond? How do we manage of folks who have a different learning style? Chandler.
I'd like to touch on this, and some of you may know this, but so I'm severely dyslexic. I was actually in special education all the way up through 12th grade, believe it or not. And so my pathway to medicine has been not traditional. And I remember in medical school when I was struggling to get into residency, I had a really hard time. I've never been a great test taker, and I got a meeting with Toby Cosgrove. And so I went into his office, and I was talking to Dr. Cosgrove, and I didn't know that he was severely dyslexic. And he said that he wouldn't be able to get into residency or medical school if it wouldn't have been for, was it Gerald Austin, which was his boss, and he got him in. So when you talk about the issues of training, I've always been very interested in finding ways to give people a more individualized course of training. And it's something with Dawn's leadership, we hope to do. And we've been trying to individualize the education plan for all of our residents because they all have different skill sets. And I tell them, I don't care what you do, I just want you to be great at it. And they all will have different missions and we all learn in different ways. So for me, that's a very important thing. And I think that with the way, I'm Generation X, but I mean, I guess I see myself more aligned with millennials, is they are much more astute at picking things up faster. And I think that there are more opportunities for there to be a less rigid educational system for people with learning disabilities to actually be incorporated and succeed.
But we've never, ever done it better than we're doing it now. When I was general surgery resident, you got handed Schwartz, 2 volumes, paper, weighed 100 pounds each, carry these around. You're going to be grilled in front of the chair every Friday for an hour, memorize this 2 chapters, which was a lot of pages. Now you have YouTube, you have V-Score, you have podcasts, you have so many resources for learning that we never, ever could even dream of. So there's a way for everybody to learn. I think that's one thing where we're doing so much better than when I trained.
And to
It's pretty
add to that,
striking to me that there used to be one way to actually become a vascular surgeon. And there was one way everybody looked alike. Everybody was a good surgeon. They did all the different operations. They were the fellow or the chief. They all did research. And those days are over. Strength is actually found in heterogeneity, and this speaks to Chandler's talk. When I put together a division, I don't necessarily want, I don't want necessarily 6 aortic surgeons. I want somebody who's interested in venous disease and somebody who's interested in PAD. That's just the clinical piece. I also want some people who are great educators, some people who are great researchers, some people who are great wellness people, and who will keep us focused on that. So I think the idea of what is the best and this speaks a little bit to what Mal was talking about, has completely changed. That our strength is in our heterogeneity now, not in our homogeneity.
So flip that, that's a great point. Flip that next, that concept, and let's think about how we train, attract, and recruit surgeons to non-urban settings. We have a lot of people in the audience who are not practicing in the big metro area. And as we train more and graduate more vascular surgeons, most of them want to be in a big city. How can we create a system so we can be more attractive in a smaller town? We've got Carrollton, we've got Rome, we've got these other places in Georgia that need surgeons. What do you think?
I have a good friend who just moved to, I don't know where in Alabama, but he had been.
Just that big.
It's just, some small city with some small town with a lake. That's all I know. Because when I called the lady and she asked me, to call about his privileging and stuff like that. And she says, "Honey, you interested in moving down to Alabama?" I was like, "I don't think you want an old Gomer like me." But anyway, I do think that, as we all know, the money's in the hospital. It's not on the sort of academic side. These hospitals need to invest in it, I believe he got sort of, part of his college debt or part of his medical school debt paid off. And so that's how I think the smaller places. The other piece of this is in the training. There are still places that teach rural surgery. And I think, you can pick those sorts of places out. At the University of Florida, we're going to have, we've got a number of community partners. We're going to have like a community track and an academic track ultimately. So I do think those are really important things.
Dawn, you want to add?
Well, I also think there's this important concept of intentionality and almost a boots on the ground mentality. So you say that most people want to move into big cities, but I don't know that that's true because there are a lot of people who are going to go home. Not everybody comes from those big cities. So you have to recruit people, and big academic centers have to intentionally recruit and train people who are going to go back into the community and serve. We have to do that. And we can do that in a variety of ways that leverages community partners and, builds a more kind of geographically thoughtful team to ultimately deliver care to patients. That's what we do as vascular surgeons.
That's a great comment. Dr. Anxiety?
Andrew Anzaitzig, Atlanta. Thank you to all the speakers. Really great session. Question for Dr. Coleman. Really like that talk. How are you able to balance all these hats that you wear clinically? You have at Michigan and now at Duke, and military and family. I know it's not just you, it's all the people around you, partners having to cover call when you're gone. What have been the major challenges you've had, and how do you make it work?
It's a really great question. I'm going to give you kind of 3 quick, easy, light responses. And the first is that since I chair the wellness committee with Mal, I have it all figured out. The second thing is that I'm really delinquent with my chapters, as some people in the audience know. But really, ultimately, the truth is that it's really hard, and I prioritize missions that resonate with what's important to me, and that's service. It's service to a lot of different bodies, including my family, but it means that I don't do everything well all the time, and that sometimes I have to say no. There's a bit of self and personal sacrifice, especially on the part of my family. But at the end of the day, it means that I ask for a lot of help, and I have a really amazing village of support to help me in that regard. I've got incredible partners and leadership at Michigan that have been really good to me for a long time to make this possible. And every time I go away, Nick Osborne steps into the program director role. All of my partners hustle and do extra clinical work to allow me to be away. Dr. Wakefield, now Peter Hankey, Justin Dimmick, they've never faulted me. They've been only supportive. And so only in that type of professional environment can you thrive? I have partners like Mao, who covers down on most of my societal obligations when I'm overseas. And I've got a husband who's just the most incredible partner who takes care of our 2 kids and relays to them the right messaging that I hope prevents them from feeling any resentment towards me when I'm away. But it's really a gift and a blessing, and I feel like it's a privilege to be able to do it.
Anybody else want to add to that? Dr. Cohn?
I'll be brief. This is really not a question as much as a testimonial. For the young people in the audience, I was a MFAS surgeon in the Air Force, and I would say that that experience, and I know there are a lot of people in this audience who have worn the uniform, and thank you for what you did and being on the tip of the spear, but for the young people, I will tell you that being in the military teaches you camaraderie and teamwork, and a term I call austere innovation, when you're told to shut up and color because you don't have exactly the clamp you need. But that fact and those skills will stay with you your whole career and will make you a better surgeon. So think of it, if you're young, it's a great opportunity, and it was very fulfilling in my life and obviously in yours.
Thank you, Jerry. Anybody want to add to that? I mean, it's inspiring. Quiet, okay.